Hello, welcome to another episode of The Healthy Enterprise. I have a very special guest today. His name is Dr. Jay Sanders. I've been looking forward to this chat. Dr. Sanders has been a longstanding medical professional, implementing organizational advancements and strategies over his lengthy career. He is also the CEO of the Global Telemedicine Group. So let's get started. So welcome, Jay. Thank you for honoring me with being on our podcast. And this episode is all about you. So tell us about who Jay Sanders is.
Huh. It's a good thing you didn't ask my wife. Well, I guess professionally, I'm professor of medicine adjunct at Johns Hopkins University School of Medicine. And I've spent the last decade and a half trying to get telemedicine started, as well as, believe it or not, AI.
Incredible. And I think when I talked to you last, you said you get mislabeled as the father of telemedicine. Is that right?
Yeah, unfortunately, I do. I guess in a way I should be happy about that, but it really doesn't give credit to the person who got me started on this, who was my professor of medicine, Dr. Kenneth Bird at the Massachusetts General Hospital, who came up to me in 1967 when I was running the emergency department. There was no emergency medical specialty in those days. So the medical resident, the surgical resident, each took 12-hour shifts running the ER. And I was running the ER this particular day, and the ER doors swung open wildly. And of course, I thought it was another Boston classic traffic accident victim.
Right.
But no, it was my professor standing there. It was a summer day, and he was sweating, red-faced, and looked upset. And he immediately saw me, and he came walking up to me somewhat rapidly. He grabbed my arm, and he said, "Jay, I've solved the problem of the traffic in Boston." Now, he had an outside office. He was actually medical director at Logan Airport Medical Station at the time. And the airport was only about 3.5 miles away from the hospital. But it used to take him an hour each way because of the terrible traffic. So I immediately said, "Well, what's that, Dr. Bird?" He said, "I'm going to buy 2 black and white TV cameras." And why he said black and white was there were no color
Right.
in those days. And I'm going to start to examine patients from here in the MGHER out at Logan Airport. What do you think of my idea? Now, you have to understand, and let me repeat, I was a resident.
Right.
He was my professor. I thought it was the stupidest idea I'd ever heard of in my life. But I had enough common sense to say, "Gee, Dr. Bird, that's a very interesting idea." And he then went to Dr. John Knowles, who subsequently became the president of Rockefeller Foundation in New York. John was the medical director of the Mass General at the time, who was an equal maverick type as was Ken Bird. And John gave him the money to buy 2 black and white TV cameras. And by the way, the communication network in those days was microwave antenna.
Right.
Every 30 miles. You couldn't go more than 30 miles. The signal wouldn't hold.
Right.
So he set the system up. And by 1969, when the system was already working functionally, I had become chief resident in medicine. And what he was doing was fascinating. And he did come up to me and he said, "What should we call this? We can't call it television medicine. Why don't we just call it telemedicine?" That's how the name came about.
That was it.
as simple and as strange as that.
Amazing.
That's how it occurred. And then I subsequently went to the University of Miami School of Medicine. To be quite candid, the reason I did was I couldn't stand the gray skies in Boston, and I loved the idea of sunshine in Miami. And the chairman then at the time allowed me to set something up, which I did in January 1st, 1970, when I got down there. The first division of general medicine in the country. Now there's a division of general medicine in every department of medicine in the country.
Right.
So if you Google me, what it really should say is I'm the father of the division of general medicine,
Right.
not the father of telemedicine. Okay, moving on. In 1973, the National Science Foundation and what was then HEW, what was then Health, Education, and Welfare. I apologize. What was then what was now HHS, which was then HEW, Health, Education, and Welfare, became very interested in utilizing telecommunications to transport healthcare. And I applied for one of their grants and got that grant, did a 3-year study demonstrating how well telemedicine worked. And then from 1976, after our grant was completed, demonstrating the incredible effectiveness of telepsychiatry, I could not get anyone interested in the country until 1991.
What? Wow. 20 years.
20 years.
That's astounding.
But it was almost worth the 20 years. One, the telecommunication infrastructure dramatically improved in the country.
Yeah.
We didn't have to use microwave antennas any longer. It was the era of T1 lines in the ground. And I got a call from the then governor of Georgia, Governor Zell Miller, who said, "Jay, I heard about your telemedicine interests. I'd like you to come up and meet with me because I'm thinking of developing a statewide television network in the state of Georgia." Now, today that wouldn't sound so exciting.
No.
But that was the first. And between 1991 and 1993, I set up a 59-site hospital system throughout the state of Georgia, connecting rural hospitals to secondary care comprehensive hospitals, and those in turn to academic medical centers. And probably one of the most important things I learned was not only the improvement of healthcare, but what Governor Zell Miller taught me about economics. And I would call it Economics 101, which they never taught me in medical school. And that was that what was happening in Georgia was happening in every state in the United States. Rural hospitals were closing. The reason they were closing was they didn't have the expertise there to deal with the types of patients that they would see. So they would have to transfer the patient.
Right. Everything would happen in the major centers.
Absolutely.
Right.
What we were able to do was fundamentally change that diagram to put the arrows going from the academic medical centers out to the rural hospitals. We were able to now bring education to the primary care physicians who were out there, increase their level of care, sustain the hospital bed census.
Right.
And next is the most important part, which was what Governor Zell Miller taught me. He said, when we first met, he said, Jay, when a rural hospital closes, what most people forget is the fact that that rural hospital was the biggest employer
Exactly.
in town. And when that rural hospital closes, the entire socioeconomic fabric of that community closes within a 3 to 5 year period of time. He was absolutely right. We were also able to demonstrate not only to be able to keep open those hospitals, but fundamentally to improve the educational level of the primary care physicians. So you saw a primary care doc doing gastroscopies. He was never taught to do gastroscopies. We taught him how to do it.
Right.
Over telecommunication.
Incredible. On the job training.
Yeah, it was, if you think about Star Trek and the transporter.
Yeah. Yeah.
This was the original transporter.
Yeah. I mean, it was very futuristic. It was very forward thinking, wasn't it?
And it was all because of Governor Zell Miller. And I also must mention the person who asked him to call me. That was the president of the Medical College of Georgia, Dr. Francis Tedesco, who I had recruited to the University of Miami initially. And about 3 to 4 years after he was with us in Miami, he asked me to write a letter of recommendation for him to become chief of gastroenterology at the Medical College of Georgia. And over a number of years, he advanced to become the president of the Medical College of Georgia. So I'm really glad I recruited him initially to the University of Miami, because none of this ever would have happened. And right after we set up our system, in 1993, I started the American Telemedicine Association, ATA, and also put in for some funding from the U.S. government. In those days, we called it an earmark. And I got funding because of another observation I made when we set up our system in Georgia. And that was that there were some patients in these rural hospitals who were being readmitted about every 2 to 3 weeks. I was wondering why in the world, particularly our asthmatic patients, who would come into the ER needing to be intubated and sent off to the intensive care unit. Then we'd stabilize them. Before discharge, they almost had normal pulmonary function tests. And then 2 to 3 weeks later, they're back in the ER. I said, wait a minute, what is happening? I said, I need to be able to see these patients at home. So I put in for a government grant to set up a system whereby I could begin to see patients in their home. This was 1995, okay? And to make a long story short, all it took was the first patient that we saw over this system to realize what was happening. There was this patient who had severe asthma. I won't obviously give you her name.
No.
And we see her in her home, and as I'm watching, she's sitting in this great big puffy chair with a cat in her lap. And her husband is watching this interchange with a cigarette in his mouth. And never wondered again why she was being readmitted every couple of weeks. And it was then that it dawned on me that the best exam room is where the patient lives, not where the doctor works.
Right.
That started the state of Arizona aimed to see our system. They put it into their yearly budget, state budget. Then the state of California came, and then everything rolled over. Every state followed the same pattern. There was one problem, though, that basically put a stop sign on all of this. And that was that for some reason, HICFA, HEW, would not pay the physicians for the care that they were providing over telemedicine.
Really?
Yeah. And when I questioned them about it, they said, well, you know what? We'll pay the radiologists, but we won't pay anybody else. And I said, well, why? They said, well, the radiologist never really sees the patient. They just see the x-ray. So I said, well, why don't you pay the pathologist? Pathologist doesn't see the patient.
Good point.
And their answer was very simply, no.
Is that the case today still?
No.
Oh, that's changed.
What changed it? They had to change it.
They had to change it.
Why? COVID.
Oh, it didn't change until COVID.
It did not change
You
until
are kidding
COVID.
me. Wow. It took COVID.
Unbelievable. So I started doing this in 1969, 1970, 1920, 2020, 15 years of a proven product
Right.
would not be paid for. So if anyone wants to look at why it takes so long, sometimes we better look at them in the mirror and question what we're doing.
It's such a good point. You know, it's and it's probably not an unusual story. I mean, and sometimes it takes major incidences to make that shift. But I mean, had you not laid the groundwork and began that process and implemented those systems already, you know, I guess to a certain extent you prepared the ground. It just took
Right.
took a lot
Exactly.
longer to get the tree to grow.
Now, a similar thing happened also in 1969 when I was chief president of the MGH. We had a weekly routine where the third-year resident would find a complex case in the hospital and then present it to me, the chief resident, as an unknown, and had me explain what was going on, or at least try to explain what was going on. And I had just finished one of these sessions, and I was saying to myself, you know, you did a pretty good job with that. And the third-year residents were leaving the room, and all of a sudden I got a tap on my back. And I turned around, and it was another professor, Dr. Octo Barnett. And everybody should look him up because he's considered the true father of bioinformatics.
Oh, Octo Barnett?
Octo Barnett. Okay? And he said, Jay, you could be replaced by a computer. And I turned around and I did exactly that. I started laughing at him. And I said, come on, Dr. Barnett. He said, yes, come on, let's try it. So he tweaked my interest and we started doing AI in 1969. Our only problem was we didn't have the computer power to really go much further. Today, we not only have the computer power, when we get fully functional quantum computing, we'll have all the computer power we need.
Yeah.
And quite candidly, eventually, AI will be much better than me.
Mm-hmm.
It'll be much better than any individual physician because it brings collective
knowledge.
expertise.
Yeah.
And it will bring the most up-to-date information that none of us as individual physicians can do. We cannot keep up to date.
Right.
The reason for the huge growth in specialty care is the fact that a doctor says to himself or herself, look, the only field I have to go into a narrower and narrower intellectual space for me to try and keep up. AI will keep up.
Yeah, that's a great point. It brings us to today that, and I want you to explain to me where you are at today and what you're actually doing currently, because, the issues with that people complain about AI and some of the technologies, it makes mistakes. It is still, you still need a human operator. You still need a human to verify or to validate. But how do you feel about that? Like, I mean, it's still early days for AI. We're just kind of figuring out how to use it and apply it in life. But bring me up to speed. Where are you at today? Because you're working with the Global Healthcare Group, right? And tell me what that is and what you guys are doing around that.
Sure. Well, the Global Telemedicine Group consists of me.
Oh.
I'm a sole consultant. I don't know why I put group there. It's probably because I was spending so much time talking to myself. That caused me to call it a group.
Your multiple personalities.
That's right. I think after this, someone's going to refer me to a psychiatrist.
Well, you can do it over telemedicine at least.
Right, exactly. No one will know. But fundamentally, let me go back to what you just said. You just said that AI makes so many mistakes. You know how many mistakes we physicians make? It's been documented.
Yeah.
In 1999, the Institute of Medicine, that changed its name within the past number of years, it's now called the National Academy of Medicine, came out with a paper called, very benignly called, To Err is Human.
Mm-hmm. Makes sense.
Unfortunately, if you read the paper, it says that we wonderful physicians kill up to 98,000 people a year from inadvertent medical errors.
Misdiagnosis.
1,000%.
All kinds of things,
then,
probably.
to back it up, in 2015, in the British Medical Journal, my institution, Johns Hopkins, said, no, to err is human is wrong. We actually killed closer to 215,000 people a year.
Wow.
From inadvertent medical errors. So no one should point a finger at AI.
Right.
They should point a finger at us.
And I suppose, when a doctor's presented with a patient problem, I mean, really, it's not like they know the answer right off the bat, unless they're a specialist, like you said. So they got to go and look at peer-reviewed studies. They got to look at what other people have done in the past, compare their current patient situation with other patient situations. Because, yeah, it might be a very similar condition, but everybody is genetically predisposed to something different, and it could react slightly different. And that's why we're seeing all these sort of like custom pharmaceuticals, because it matches each person's genetic information, plus the disease that they might have slightly different genetic combinations as well. So I guess in that sense, it's right. It's collecting all this data, all this information, and then you're using that to actually streamline processing all that information to get some sort of prognosis or diagnosis.
Well, I should be interviewing you, not you interviewing me, because you hit the nail on the head. The fundamental, first of all, let's look at a broad scope. What a lot of people don't realize is that healthcare today, medicine today, is statistically based. It's not individually based. because we don't use an individual's genetics.
Right.
An aspirin may be 95% effective in reducing coagulation and reducing a thrombus,
Right.
a thromboembolism to the lung, okay? But what about the 5% who are put on aspirin who it doesn't help? Genetics need to be incorporated into our evaluative system. And we now know what the genome is, and the cost of getting a genetic analysis has gone down dramatically. Every child at birth, when they stick your heel for your blood type and the other inborn errors of metabolism that they're checking for, they should also get a little extra blood to do a genetic analysis.
Yeah, right out of the gate.
And now the third thing, telemedicine, AI, and medical sensors that are programmed to your genetic makeup. And now we go from healthcare that is reactionary, i.e., we take care of you after you get sick,
right,
to healthcare that is anticipatory, in which you and I, as the patient, become the primary care physician.
Right.
Because we are now have the appropriate AI and medical sensors that we're wearing in our shirt, in our belt, on a ring, on a watch, that tells us, you know what, something's wrong. We better go do something about it. We go from reactionary healthcare, where you go into your ER because you just got sick, to anticipatory healthcare, where you prevent the illness in the first place.
Right.
That's where our healthcare delivery system needs to go.
Right.
Now, whether it's going to take the 50 years it took me to get telemedicine going, well, I won't see it. I'll be long gone. But we need to become realistic about what is wrong with our healthcare delivery system and get rid of our egos and begin to use some of the technologies that we developed and let that be our ego.
That's right. Right. That's the trophy at the end of that. Like that's what, lead all this, like 50 years of or more, longer, hundreds of years of collecting information and data could bring us to this point where we're leveraging technology to make not only doctors' jobs easier, but actually the patients' lives easier, so we can, like are you saying more or less self-diagnose or have the information to understand what your condition is in advance, right?
Absolutely.
Right. Or what
absolutely
what your potential, what your genetic potential is, I suppose, for being predisposed to certain illnesses.
But there's actually a very simple way to do it that protects everyone's ego. Everybody has electronic medical records these days.
Yeah.
Certainly in Canada, certainly here in the U.S.
Yeah.
Okay. Why don't we put an AI genetic system into interrogating every patient's physician's EHR, looking at their history, their physical exam, their differential diagnosis, their laboratory data, their radiological data, and comparing it with the most up-to-date database, constantly changing as new information comes aboard, and then notifies the physician, hey, by the way, based upon this patient's genetics, this medication is not going to work for this condition, but this other medication will work. And it notifies the physician, doesn't embarrass the physician, okay? And the physician notifies the patient. And by the way, it won't cost the physician anything, and it won't cost the patient anything for the system to be developed.
Right.
Because guess who's going to pay for it? The physician's malpractice insurer will pay for it.
You're right. It sure will.
And the hospital's insurer will pay for it. That's the solution.
Well, I mean, they're the ones that are paying the bills at the end of the day when somebody gets sued, and yeah, they're getting paid. They're getting paid by the patients already too to cover those costs. Yeah,
Absolutely. Absolutely.
you were talking about sort of connecting all the data, so you connect all your lab results and your doctor's notes and the visits to the specialist, et cetera, et cetera. I can't even. You can't even right now. You can't even get drugstores to connect their information so that if you happen to go to a different drugstore for a refill on your medication, they're not talking to each other. Everything's a closed circuit. So, one series of drugstores has it. So if you can as long as you go to their drugstore, they got your data on records. Sometimes I've even run into that where it's, it's a drug store chain and they don't actually they can't even talk to each other and they are in the same company. So what are the risks of that, of bringing all that information into one place, all that very sensitive information about each individual and their information? Do you see risks there? Do you see that some people will just be opposed to one giant health medicine data center that holds all that information and connects all the people? Are there risks? Do people think, I mean, someone's bound to want to take advantage of that in a dark
Oh,
and evil
absolutely.
way, but
No, absolutely. I think that's a very pertinent uh, question. I haven't thought a lot about it,
yeah,
but there are going to be cyber attacks.
yeah, yeah,
I think the more we put data out electronically, um, the greater attempts are going to be to break in
yeah.
to that database. And on the opposite side, there'll be greater cybersecurity. Yeah, I
Someone on the
totally agree. There will be problems.
But if you can imagine the advantages of all that coming together, where all that information is stored, collected, and then analyzed by AI, and results are presented.
Absolutely.
It would be a whole new world.
Yeah.
I mean, the pandemic, it shifted a lot of perspectives in a lot of ways. So, and in some cases to the good, but it also exposed a lot of weaknesses. And I think the healthcare profession and the medical industry realize that. I mean, the capacity overload, the shortage of doctors, the burnout of frontline workers. I mean, it was rampant, and we aren't prepared for those kinds of situations, are we?
No, we're not. I mean, we have organizations in each country um, that is constantly looking at potential cyber attacks. I think our capabilities will become more and more sophisticated the more of these types of systems get developed. So it's going to be a chain or wheel type of effect.
Mm-hmm.
Whether that should stop us in this initiative,
No, we got to keep pushing
no,
ahead. Yeah,
no. I'd rather know that I'm getting the right medication
yeah,
for my illness, and the fact that somebody else knows that I'm taking this medication. I really don't care if it's helping me.
yeah, yeah. It's a good point. Yeah, you're a visionary. Like you've been doing things since you started your career. I mean, we didn't talk a lot about it, but when you know, developed the division of general
Medicine.
medicine, yeah. I mean, you were already uh, trying to create new ways of doing things better. And what inspired that, anyways? What brought you to that decision to start that?
Well, that also happened during my chief presidency year. One of the things that the chief president was allowed to do every day was to choose a different team to work with. And when I say work with, really to attend their attending rounds. And basically, a an internist specialist at the hospital would be assigned on a monthly basis to a particular resident intern team. And he or she would come around at 10 o'clock in the morning and make rounds on all the new patients that came in and to go over any problems that existed on the previous, that may have come up over the previous 24 hours. And one of the things I noted, I was really just a guest. I could sit in, though, on any of these rounds,
right,
just as an observer. And one of the things I observed was quite startling to me that I never really realized when I was a resident. And that was, I'll give you an example. Let's assume a patient came in who had diabetes and had a diabetic foot ulcer. Now, diabetic foot ulcers are caused by a neuropathy that the patient has, a nerve problem that they have. But if the attending was a cardiologist, he or she would spend the entire hour talking about diabetic cardiomyopathy and nothing about the neuropathy. So the residents left attending rounds knowing everything about diabetic cardiomyopathy, but nothing about the patient. And I said to the chief of medicine at the time, who was Dr. Alex Leaf, just a wonderful human being, and great doc, who said, Jay, I'd like you to stay here at the MGH, and I'd like you to run a division. I'm not going to mention the division for personal reasons, because the head of that division, who was head at the time, who I was going to replace, if I took Alex Leaf's suggestion, was a good friend. So he said, I'd like you to stay here to run this division. And I said, thank you very much, Dr. Leaf. And I had taken some specialty training in that particular specialty area. And I said, you know what? One of the major problems here at the MGH, which is a well-known institution, is what I just described to you. The fact that the residents are learning what this particular doctor knows, but nothing about the patient that just came in.
Right.
I said, what I'd like to do is develop a division that is made up of faculty that have a very, very broad base that can handle 85%. Those are my exact words. 85% of the patients who come in and help the house staff take care of that patient. And he looked at me and he said, no, I want you to run this present division. And I said, well, give me a couple of weeks to think about it. About 2 weeks later, I got a call from Dr. William Harrington from Barnes Hospital in St. Louis, who had just been named the new chairman of the Department of Medicine at the University of Miami. He said he wants me to come down to run the house staff, which was great for me. I said, Dr. Harrington, would you also let me start a new division called the Division of General Medicine? And he said, what's that? I explained to him what I'm explaining to you. And he said, well, I really don't know what that is, but if you want to do that also, you can. So on January 1st, 1970, when I first got to the University of Miami, I started the first division of general medicine in the country. And that's what I'm the father of. And I'm the father of my 4 other sons, but not the father of telemedicine, despite what Google said. It's Ken Bird.
Maybe you're the son of telemedicine, or the nephew of telemedicine, or something like that.
I'm the nephew, right?
Oh, that's great. You've been, in a way, you kind of been working organizationally to simplify and streamline and innovate healthcare for so many years. I mean,
much to my dismay.
you've come a long way. So tell me, what's on your desk today? Like, what's paramount for you when you get up every day? What are you working on that's the most important thing right now for you?
Well, as I mentioned, I'm a consultant in the areas of telemedicine, AI, and medical sensors.
Mm-hmm.
Sometimes I feel more like a cheerleader than a consultant.
Yeah.
But yes, that's what I'm doing, because then we'll have that kind of healthcare system that we really need.
Right.
From birth. And it'll be an anticipatory health system. You and I will be the primary care practitioners
Mm-hmm.
for our own health.
Right. And so when you're consulting, who are you consulting with during this process? And what kind of challenges are they facing through this?
Well, first of all, we should underline challenges.
Okay.
Because I really have to explain the rationale and the logic, and then identify some of the better technologies that are out there. For instance, you may find this crazy, but just as one example, I view Alexa as a technology that I can incorporate your personal medical background into, as well as your genetics. And Alexa, or the Alexas of this world,
right,
the AIs of this world, will be in your home. I know you're going to laugh, I see home builders, I see home security companies knocking on your door and saying, look, we provide, like ADT, we provide home security, but we also provide you home health security technology.
Yeah. I believe that.
It will tell you whether or not you've forgotten to turn off your gas burner in your kitchen. It will let you know, by the way, it's time for you to take your medication.
Right. Right.
Okay? Even if you have Alzheimer's, it's going to tell you you need to take your medicine at this point in time. By the way, don't take this other medicine that you just bought at the store. It's not going to work. As a matter of fact, it's going to create problems for you.
It's going to conflict with your other medicine or your vitamins or whatever.
Exactly.
Right.
I think as I mentioned or tried to mention before, we need to become more responsible for our own health.
Yeah.
The same way we're responsible for crashing into another car by our driving.
Right.
We need to take care of our own health. And we go to the doctor when we don't have a choice, okay, when what we're doing is not working. But we need to be our own primary care physician.
Yeah, before it gets to that point.
Absolutely.
Right. Yeah, when you're at 911, it's not really much help when you haven't paid attention along the way. I mean, just going back to the lady with the cat and the smoking husband, I mean, what we're doing in our living rooms and our kitchens and our, at home is more important than, really the byproduct of that, which is some sort of condition or illness or something. It's where we're at.
Absolutely. And in a way, we're moving in that direction.
Yeah.
Perhaps the wrong way, but maybe we'll get there. And that is the new hospital at home program.
Right.
Where we're taking care of a lot more patients in their home.
Yeah.
Rather than keeping them in the hospital.
Right. Well, I mean, they do have the telemedicine model is really, and since pandemic, it's really quite, it's been activated. It's probably quite popular now.
Absolutely.
Most initial visits, I'm understanding from doctors, family physicians, are over the phone, video calls, just to kind of get an idea of what's going on rather than, there you go. We take them with us everywhere we go.
Yep.
Yeah.
Yep.
Yeah.
Exactly. We're connected.
We are. We all are. And I'm glad we're connected. I've really enjoyed this conversation. I knew it was going to be great, and I knew we would probably need more time. So you might have to come back for another chat one of these days here soon.
Sounds good.
Yeah. And, Yeah. So to wrap up, what's ahead? What do you see? What do you see in the near future for you? Where's what are you excited about?
Well, let's deal with your first question. What do I see for me? I guess being able to continue to proselytize where we need to go. But I'll be very candid. In July, I'll be 88, so I'm not sure I have that much more time, but I'm counting on you to do that.
Well, man, I didn't guess you're 88. You're doing awesome.
Well, thank you.
Yeah.
Thank you.
And you're still not retired.
No, right now I'm only driving my wife crazy, but I would probably drive everybody else crazy if I retired.
And then I had one other question. What was it? I said, what are you excited? Oh, what are you excited about? Are you going on any vacations, or are you just are you working on this project?
No, working on this project.
Yeah.
Yeah. I started a long time ago doing this.
Yeah.
I'd like to see it finally accepted,
yeah,
adapted.
What's that going to take? What do you think? What do you need? What if you could resolve this tomorrow and woke up tomorrow and it was where you want it to be? What does it look like?
Well, if you had a magic wand, yeah,
wave that around.
Wave it as rapidly as you can. No, it's going to take time.
Yeah.
I'm old enough to know that we don't change our minds very quickly. And the complexity of what it takes. Here in the U.S., the complexity was a simple one. Two things happened. One, a pandemic, and two, the government had to let down and pay for it. And then finally, people began to realize the potential value of AI.
Right.
And I hope it continues to accelerate because it's desperately needed. But it can't be generic like our system is today. It's got to be specific. The only way it's going to be specific is to integrate genetics.
Well, one thing I agree on is that AI is be much better applied and more useful to us than using it for deepfake videos and blog posts.
Let me end. Let me end with this. I view telemedicine as simply providing access. It doesn't provide accuracy. AI is going to provide accuracy. Sensors with generics are going to provide specificity.
Right.
Those are the three critical components.
I love it. Access, accuracy, and specificity. That's not easy to say. We got to find a better word. Specifics. This is great. Thank you, Jay, so much. It's been a pleasure, and definitely would like to have you back if you're up for it. But it's been great having you on the podcast. So thank you for your time.
Oh, you're very welcome. And you better, if you're going to have me again, you better do it quickly, given my age.
Okay. You got it. Speaking to somebody who has been working as long as he has in the medical profession, and how innovation was happening for him, 50 years ago. He was like on the front lines of telemedicine, which is pretty remarkable that, of course, then it took until during the pandemic to actually roll it out and where it's become mainstream. But I think, he's kind of had a whole career of always being ahead of the curve, modifying, simplifying processes, incorporating new ways of looking at how healthcare should work. So, a pioneer in a sense in technology also. And even now, still at 88 years of age, Jay is still pushing the envelope, with taking telemedicine, which what he says is the access to medicine and medical professionals. AI, which he believes is going to improve accuracy and speed, obviously, for the process. And then sensoring, which is going to advance our perspective of medical support as being more preventative as opposed to reactive. So fantastic conversation. I thoroughly enjoyed that. I'm going to have him back because after we were recording, we were talking about genetics. So, but that's a subject for another day. We didn't have time for any more than that. I do want to point out that Dr. Sanders has a book out called Digital Medical Home. It's co-written with Michael S. Gorton. And so I'm going to get that. I'm going to order that book right now. How the Telemedicine Revolution Ignited the Creation of Precision Health. So there you go. There's a book you can go check out of Dr. Sanders. Thanks for listening, and stay tuned.